We are now live, so hello web shadowers. Thank you all for attending our session this afternoon. Today we have the pleasure of hosting Dr. Farooq, who will be teaching us about radiology. As always, please remember that the Google form will be posted in the chat box at the end of the session, and it will also be in the description. So with that being said, Dr. Farooq, you may start whenever you're ready.
Thank you so much for the introduction. I appreciate it. Guys, I'm so happy to be here. As always, doing these presentations is really something that I enjoy and I'm passionate about. And today I really want you guys to answer the question for you is, what's a radiologist? So a lot of you are probably already familiar with what we do. But the fact of the matter is that when I go out into the real world and talk to the average person who asks me what I do, they have no idea what a radiologist is, what we do on a day-to-day basis, what's involved in our training, et cetera, et cetera. So we're going to talk about that. I've listed my social media contacts here on Instagram and Twitter. Feel free to reach out to me. I'm going to put them on again towards the end of the presentation. And I've divided the presentation into two parts for you guys. The first part, I'm going to talk to you a little bit specifically about my journey into medicine, my journey into radiology, a little bit about the field of radiology. And then the second half is going to be a little bit more interactive, where we're going to jump into some cases. So I want to start out with this picture. And this picture, I feel, is the most important part of my presentation. The 7 people pictured here, other than myself, are pictured here on my wedding day, and they are the most important people in my life. My husband, my siblings, and my mom and my dad. And they are such an important part of my story. So no story about my journey into medicine is complete without them. And our story involves a transcontinental migration, and it involves three transplants and the father of heart transplant surgery. So my older sister was the reason we moved here, across oceans, across countries, and we moved across coasts for my sister's heart transplant, which was done by Dr. Norman Shumway, who is at Stanford, or was at Stanford. He has since passed. And he operated on my sister for her heart surgery. And then several years later, when I was in high school, my mom had a bone marrow transplant for breast cancer treatment. Fast forward another 7 years, and my older sister again had a liver transplant surgery. So all in all, my family has been involved with 3 transplants, saved 2 lives, and many, many more lives have been transformed as a result. My father's a physician, my mom is a physician, my brother's in med school, I went to med school, my sister's a pre-med, my other sister is a dentist. And the compassion and kindness that were shared by so many of the healthcare providers who were involved in my family's journey through medicine have influenced the way that we provide care and the way that we interact with our patients and dedicate our lives to medicine. So this is the background behind my journey, and I hope that sharing it with you guys gives you some insight into how you can use your family and your some of the most difficult things in your life to keep you motivated throughout the journey in medicine. So without further ado, I'll tell you a little bit about specifically the journey that I've had from undergrad, where I went to the University of Georgia, double majored in biology and ecology. Then I went to the Medical College of Georgia, did my internship in Atlanta, and now I'm in my 3rd year of residency in radiology in Long Island. So as you can see, all in all, it's been more than a decade starting from pre-med through residency. But I wouldn't give that up for the world. All of the knowledge that I've gained, the friends that I've made, the compassion and empathy that I've learned to show myself and other people, I wouldn't trade that for the world, despite all of the challenges that are inevitable in a career in medicine. So I wanted to share a couple of slides with you guys about choosing medical specialties. This is a slide that was created by someone. I unfortunately don't know who created it, so I can't give them credit. But I do think it's a little, it's funny, it's interesting in the context of medicine. It makes kind of, it's a little bit humorous. So people say, if you don't know what to do, you start asking yourself, hey, what's the problem? You don't like anything, you like nothing. And then, do you like interacting with people? How are your grades? So instead of taking you down every pathway, I'm going to take you down radiology's pathway. So someone here would say, I like nothing. Your grades are really good. You don't like doing surgery. You're socially awkward. So you go into radiology. So as you guys can see, this is pretty, is it funny? Yes. Is it accurate? We'll see. This is another chart that was done by a medical student talking about stereotypes in medicine. And the bigger the words are, the more the stereotype sticks in medicine amongst medical students, amongst other doctors. So I'll draw your attention here to radiology. And the big words are boring, dark, visual, lonely, reclusive, pedantic, meticulous. And that's how other people describe radiology. But how do I describe myself and other radiologists? I would say I'm describe myself as curious, motivated, funny, great sense of humor, personable, and very focused when it comes to what I do. So as you can see, this is pretty much very much in contrast to what other people's perceptions are. And what I want you guys to take away from this presentation is that you're going to hear stereotypes sort of across specialties, and different people are going to say different things about other specialties. And that really doesn't matter. What matters is your assessment of the people that are talking to you, your assessment when you go spend time with these people. Do you feel like you could get along with them? Do you feel like you have something to add? And the great thing about a modern medicine is that we're looking for diversity. So even if you don't fit the bill, even if those major stereotypes aren't something that you think you necessarily fit with, you shouldn't discount yourself, because you could be the person that brings in a fresh new perspective. And that's what we're looking for in all of the different subspecialties. We're looking for diversity. So don't get trapped in these stereotypes. Don't get trapped in these pathways that people kind of say when you say you don't know what you want to do. You figure that out for yourself. Go out there, explore, listen to different people, talk to different people, and get an idea for yourself and figure out what you want to do, because you're going to be happiest in the place that you really enjoy, not happiest in a place where people project their stereotypes on you. Okay. So with that said, I want to bring a different perspective today into radiology that a lot of people might not have talked about before. So when people think about medicine, surgery, psychiatry, even, right, they talk about global health. But not a lot of people think about global health and radiology. And that's something that I'm really passionate about. During my residency, I started a Rad Aid chapter and the first Health for the World chapter on Long Island. And I'm chapter chief. I'm also involved as a volunteer manager in Rad Aid. And it's been such an awesome journey. I've gotten to meet so many different people around the world talking about how we can bring non-invasive imaging to different parts of the world that are underserved, and even underserved parts of of our country in North America, Canada, and the US. And I'm really passionate about it. I think it's one of the simplest ways that we can make a huge difference in the health of the world globally. And I just wanted to point out to you guys that these are options and different ways that we can do that. So don't let the fact that radiology is a very technologically heavy field make you think that we can't be forces of change within the world globally. So with that said, another misnomer that people have about radiology is that we just do one thing, right? We sit there and we interpret chest x-rays, but there are so many different specialties within radiology, a lot of which I didn't even know when I applied for it. And I've divided them in specialties on the left that are interventional and have a large physician-patient contact within them. So breast imaging, interventional radiology, musculoskeletal, and nuclear medicine radiology have heavy patient interaction. They're very procedure heavy. And then the subspecialties on the right of the screen, pediatrics, neuroradiology, body, chest, emergency. These are for people who may not want to interact with patients as much and who just want to be involved in interpreting imaging, imaging technology, artificial intelligence. There's so many different avenues to get involved. So as you can see here, there's just such a breadth to radiology. So literally, no matter what you want, you can find it within this field. And next, we want to talk about modalities of radiology. And this is also another one of my favorite slides, because if you think about the fact that 100 years ago, we couldn't look inside the human body without either cutting the patient open with surgery or doing an autopsy after the patient was dead. And fast forward to 2021, where not only can we look inside the body without opening it up through non-invasive imaging, but we can do it through so many different modalities. We can use one-dimensional x-rays. We can use, three-dimensional x-rays with CT. We can use magnetic imaging with MRIs. We can use sound, the physics of sound with ultrasound. So it's just so miraculous and so amazing that we can use all of this technology and within 5 minutes, up to 20 minutes, look inside a patient and tell you exactly what's wrong or what's going on, diagnose cancer, see if cancer has advanced or not, diagnose infection, treat infection. So it's really such a cool advanced specialty and a testament to how far medicine has advanced over the course of the year of time, that you can't really say about a lot of different specialties. And with that said, now that we have all of that technology, all of those different modalities, how do you approach an image, right? You have so many different options. You have so many different avenues to do this. How do you even go about interpreting an image when it comes to you? So the first thing, the approach that I take is, first off, what's the modality am I looking at? And then how was the image acquired, right? Did the patient walk down to the x-ray department? Did they have to take the x-ray up to the ICU to take the image? What's the history? What's the chief complaint? Is the patient coming in with a fever? Are they coming in with leg pain? Do they have a history of cancer? And then going down my search pattern, how am I going to look at each image? And we'll go through some examples later of this. And then talking about pertinent positives and negatives. Does this patient have a large heart? Do they have a normal sized heart? Are there any findings or abnormalities on their bones, on their liver? And like I said, again, we'll go through some examples of this in a bit. And this is just a slide talking about imaging planes. So when you take a human anatomy class, they talk about the planes of the human body, right? So if you are just think about yourself going from the front to the back of your head, that's the coronal image, okay? And if you go from the right to the left side of your head, that's the sagittal plane. And if you go from the top to the bottom of your head, that's the axial plane. And these are the standard planes that we use for imaging as well. And finally, we talk about descriptors, right? So when I get an image, I'm going to generate a report talking about the findings of that images. And I'm going to do that using descriptors so that I can translate everything that I see on the image to the ordering doctor. So they can just read my report and say, okay, this was what she found. This was what was in the images. And so an example of that is the heart is grossly enlarged, right? What am I communicating? The anatomy, the heart is enlarged. It's bigger than normal. And then I'm telling you the severity. Is it mild, moderate, severe, grossly enlarged, is markedly enlarged, right? And so this is how we go about generating our reports for the referring doctors and really giving them an idea about the severity or lack of severity behind what we're seeing in our imaging. So we're going to jump into the more interactive part of the presentation. So hopefully I've communicated to you guys by now that radiology is a very visual specialty. And the best way to really get an understanding of what a radiologist does is to look and see, right? Go through all of the different modalities, go through some examples of normal and abnormal. And really, that's what we're going to spend the next couple of minutes doing. So here are some cases. So I'm just you guys can type in the chat box, the answer to some of the questions. So I'm just going to ask you guys, this is a normal chest x-ray. So that's the modality. Can anybody tell me what imaging plane we're looking at this in? So we talked about frontal, sagittal, we talked about axial. What projection is this? And you can type that into the chat box if you want. And so we talked about this chest x-ray. This patient came in with a history of being pretty asymptomatic. And they also, and so the search pattern that I would use is that the trachea here is normal. The heart border looks good. And then we've got our aorta, we've got our pulmonary artery, we've got our diaphragm. Underneath the diaphragm, we've got the spine, the ribs, the scapula, the clavicle, and then we just look at our lung fields. They look clear. Everyone's saying coronal, excellent job. This is a coronal on x-ray. Sometimes we just say frontal imaging. So you'll hear that as well. They might also say AP, anterior to posterior. All of those are referring to the same things. And you guys are spot on. This is a coronal or frontal image of the chest. And this is normal, okay? So now we've practiced that. We're going to go to an abnormal chest x-ray. You guys can type in the box what you think this finding is, but I'm going to take you through my approach to the image. So again, chest x-ray, this is a coronal or frontal projection. And we're going to go through our search pattern. So trachea, the heart, the right heart border is obscured. We've got a below the diaphragm looks fine. Our bones look pretty good. And then of course the arrows are pointing to this silhouette or this consolidation, which is silhouetting the right heart border. That's a term that we use in radiology. If you guys know the diagnosis, feel free to type it into the chat box. I'm going to give you a clue that this patient has fevers and chills. Fevers and chills in the setting of a consolidation in the right middle lobe that's obscuring the right heart border. Does anyone have any ideas of what this could be clinically? So different things that can happen in the chest, could be fluid in the lungs. I like that. With somebody that has a fever, what's more common? There you go. Infection. Very good. Right. So, and an infection in the lungs is called pneumonia, right? So that's the diagnosis. Excellent. So you guys just did what a radiologist does every day, right? You go through the modality, through the projection, you look at the finding, and then you put it in context of what the history was to get to a diagnosis. Excellent job. All right. So now we're going to move on to a normal CT. Again, you guys can put the projection in the box. I've already told you this is a CT. So type in the chat box what you think the projection is. And I'm just going to take you through some normal anatomy in the meantime. So we've got the base of the heart, the base of the lungs, and we've got our liver here, the portal vein, the gallbladder, the stomach, a little bit of the spleen poking through in this projection. We've got the small bowel, the mesentery. We've got large bowel, cecum here, the bladder, pelvic bones, hip bones. We've got musculature of the hips and pelvic bones, ribs down here, subcutaneous fat. These are all things that we look at when we're looking at a CT scan in this projection. So I don't see anything in the chat box, but I'm going to go ahead and tell you guys this is a coronal CT. This patient's history was asymptomatic, and this was, of course, a normal CT. So we're going to go through another example. And if you guys have ideas about what this finding could be as I describe it, feel free to type it into the chat box. So again, we're looking at a CT scan in the coronal projection and coronal plane. And we see the base of the lungs. We see a little bit of the heart here, the spleen, the bowel, some contrast in the kidneys, the spine. And here we see the margins of the liver, but what really stands out is a large mass, right, within the liver. And it's heterogeneous because different parts of it are looking different, right? This part's dark, this part's bright, but it's pretty well circumscribed, the borders. And these are enhancing, and we know that there's contrast on board because you see some contrast within the collecting system of the kidneys. So this was a young patient. Yes, the liver is slightly enlarged, great catch. But this patient was asymptomatic. And so this is a little bit of a tricky case. But in an asymptomatic person with a large mass, tumor is a good thing. It's definitely something what we want to consider. But this is a hemangioma. And this is a classic pattern of a hemangioma that fills in with peripheral enhancement and then centripetal enhancement. And when they get this large, we call them giant hemangiomas. And, sometimes just by the fact that they are so big, the patients can come in with a little bit of pain from the pressure, but typically they're asymptomatic and people don't even know about them until they get imaged. So, but tumor is a good thought. Enlarged liver could, sometimes happens in these just because the mass is so big. But this is a tricky case. And again, you learn in training what are the characteristic features of different things so you can differentiate something benign like this from a malignant lesion or a cancer. Because the fact of the matter is if you can tell what this is on imaging, you don't want to go in there and have them poking around with needles or surgery because that can cause unnecessary complications. Someone asked, why would they get imaging if they were asymptomatic? That's a great question. You will see in medicine that a lot of times patients get imaging for other reasons. So in this particular case, the patient came in because they were having chest pain. So they got imaging of their chest, a chest CT, and the chest CT goes down to the top of the liver. So the radiologist noticed that there was a a mass in the liver. And so they recommended dedicated imaging to further evaluate that mass and make sure it wasn't tricky or something more concerning. So this happens a lot in radiology. Oftentimes we have what's called incidental findings, where we're looking at a completely different part of the body, the chest or the brain, and we see something that's concerning for a tumor or something else. So we recommend imaging of another body part just to make sure we're not missing something. That's a great question. Very good catch. All right, so moving on to our next modality here, we have an ultrasound. So this is a sagittal ultrasound of the uterus. And we see the uterus here, we see the vaginal canal with the bladder. And this is just a normal case. The patient just presented with a little bit of vaginal discharge. They were concerned, so they did an ultrasound, and it ended up being normal. So this is the case. I want you guys to go ahead and type in what you think this is. Hopefully you guys, if you have trouble, it's not a big deal. It's hard if you haven't seen these before. But while I'm talking, I'm gonna go ahead and give you guys a chance to think about it. So again, this is an ultrasound, sagittal view of the ultrasound, and we see a yolk sac within an intrauterine yolk sac. And the history of this patient was that she missed her period. So I'm going to give you guys a couple of seconds to type in the chat box what you think this is. Hopefully everyone has some idea of what this could be. All right. So while we're waiting on that, just a couple of things. So whenever we're looking at the uterus, yes, very good. Someone typed it in, pregnancy. Especially age is really important. Okay. So I always, the first thing I want to know is how old is the patient, because if they have the potential to get pregnant, that's the first thing I'm going to be looking for. That's the first thing I'm going to be thinking about. And if they are pregnant, the next thing I'm going to be looking for is complications of pregnancy. So you guys are absolutely correct. This patient has an intrauterine pregnancy. A lot of times though, when these patients come to us, they already know they're pregnant, and they're more concerned because they're either having vaginal bleeding or they're having pain, and they're concerned that something might be wrong with the pregnancy. So part of the role is to check for viability. Are we hearing a fetal heart rate? Is the pregnancy in the right spot? Because sometimes you can have the yolk sac implant into different parts of the uterus that aren't normal. They could implant into the cervix, they could implant into the fallopian tubes. And sometimes you have sad things that are happening where, people are, there is no fetal heart rate and there's an abortion. So, we always have to be careful. We have to look for these things, do our due diligence as radiologists. I oftentimes will even go and talk to the patients, just talk to them, about what medications they're on, sort of when did the bleeding start, what's been going on, just to get a little bit more idea of the context of what brought them in, because it's really important, when you're talking about pregnant patients, that we do the best that we can for them. So very good. All right, so we're on our last case here. And this is a modality that not a lot of people are familiar with, even medical students coming into radiology, is a mammogram. So breast cancer is one of the top cancers in women. It unfortunately can be deadly if not picked up in time. It can be metastatic. And what we as radiologists do is we screen for breast cancer. And we screen for it using what's called a mammogram. And in mammogram, our imaging planes are a little bit different from what I talked to you guys about earlier. Instead of doing our typical sagittal, axial, coronal, we do what's called a craniocaudal or a medial lateral oblique. And that's really complicated. So I don't want to, you guys to delve too much on it. Just take my word for it. They do different imaging planes because of the way that the breast is positioned within the X-ray detector. And so just some normal anatomy on here. This is the pectoralis muscles in the back here. And this is the skin of the breast. Here we have the nipple and a little bit of retroareolar glandular tissue. And most of the breast has been replaced with fat. Typically, this occurs as women get older. Their normal breast tissue gets replaced with fat. This is another case of a mammogram. And this was a craniocaudal imaging plane. Here we have a spiculated mass within the lower outer quadrant of the left breast. This was a patient with a family history of breast cancer. And what are some thoughts? What do you guys think about this? While you're typing your answers in the chat box, I'll give you a little bit more information about this. So breast cancer, a lot of people get diagnosed with it actually don't have any family history of breast cancer. That's why it's so important to screen for it. So after the age of 40, we recommend all women get an annual breast mammogram to go get that taken care of. And you can have lots of different pathologies in your breast, not just breast cancer. Women can get fibroadenomas, which are benign tumors. They can get phylloides tumors, which are also benign. They can get cystic changes. They can get hamartomas. So lots of different pathology within the breast. I don't see any answers in the chat box. I'm going to go ahead and just tell you guys that this did end up being a breast cancer. And someone typed in axial in the chat box. So like I said earlier, breast imaging is a little different because of the way that it's imaged. We don't use our typical axial, coronal, and sagittal imaging planes in mammograms. But that's, again, a little bit complex and not something you guys need to know about right now, but just so it's out there and something you've heard of before. Someone says it looks like calcification or a nodule. Yeah, we use specific terms in breast imaging, but you're very right. There is, it's not really calcification because it's not very dense like a bone, but it looks like a spiculated mass, right? Like it has kind of spicules coming out of this nodular looking thing. And so there are very specific descriptors that they use for that, but you're right on in that it does look nodular and it looks bad, right? I mean, at a very fundamental level, you would be concerned about this. You would biopsy it and you would have to make sure that this is not cancer. All right. So that's it for our cases. You guys did a great job with that. You guys were spot on. And I think you got the idea of kind of a very general look at what we do on a daily basis, obviously at a much faster pace and much higher volume. But essentially, the idea is that radiologists we're detectives, right? Like you give us an imaging study and you make findings, and then we put them in context of all of the clinical information that we have to come to a diagnosis that makes the most sense. And I think it's really important to understand that we play a fundamental role in imaging, whether it's transplant patients, preoperative, post-surgical, looking for complications. And radiology, I think that's what makes this field really challenging at times, is because there's so much to know about all of the different organ systems, the pathology. You have to know about every different type of surgery. And as all of these things continue to evolve, we have to keep learning about them. We have to stay on our toes. And I just think it's one of those fields that if you're a lifelong learner, if you're somebody that, doesn't really want to be the smartest person in the room all the time, you're going to love this field, because it is something that you're just constantly learning, you're constantly getting better, and you are helping to advance the field of medicine in a way that not a lot of other people can say they are. So with that said, I wanted to leave you guys with a couple of slides just about just some pearls. With this whole presentation, my goal was just for you to consider this field. I think it's fantastic. I think there's great work-life balance. I think it's one of the coolest fields in medicine. And like I said, 100 years ago, we had no way to do this. Fast forward to now, we have so many different ways to do this, and that's truly amazing. Feel free to contact me on any of my social media outlets. I'm always happy to talk to you guys. Even if I'm busy, even if you don't hear from me and it takes a couple of days, I promise I will reach back out to you. And advice for you guys is, people are going to give you, this is how you study, this is how you work, this is how you, do this. My advice is very fundamental. At every stage of your career, whether you're a pre-med, a medical student, a resident, a fellow, networking is so important. Whether it's within your specialty, outside of your subspecialty, it's just so important to get your name out there, have people know who you are, talk to them, and just get to know different perspectives. It's going to be so helpful. You never know when somebody that you've reached out to is going to be able to help you or make connections for you. This is the one thing that when I started doing it, my career changed. And the trajectory of my career, the trajectory of my training has changed drastically. So, it's my number one, my number two, and my number three key piece of advice for all of you. And finally, I want to address something that a lot of people don't really talk about, but I think it's really important to understand, is that no matter where you are in your journey, there are always going to be people who doubt you. There are always going to be sort of people who want to seed something in your head about why you can't, or why you shouldn't pursue something, or why you should consider something else. And my advice to you is, you really have to put your blinders on when that happens. And just remember that the most important person in this entire process is you. And that's what you have to focus on and remember. And, in one ear, out the other with those comments and with those thoughts. Do not let them seep into your head and let them become something that you start to tell yourself. The most important message is the message that you tell yourself. And so believe it, achieve it, all of those things, whatever you need to say to yourself every day, say it, because that's going to make the biggest difference. And with that said, thank you so much, you guys, for your attention. I really love that you guys have been so interactive in the chat box, and I hope you enjoyed this. I hope it was helpful, and I'm happy to answer any questions that you guys might have. Okay, the first question: can you explain your knowledge of applied physics in radiology? All right, so that's an intense question for a first question, but I like it. So physics is something that kind of draws, it can be twofold. It can either really, if you're very mathematical and very physics oriented to begin with, it's something that draws you to the field. But if you're not, it can be something that deters you from it. And I would say that we do use physics, but it's medical physics. So the physics that we use is really an understanding of radiation and how it impacts our protocols that we use for different types of imaging, and how to decrease dose, how to modify, and how to be safe, essentially, as we're doing procedures and things like that. So, it's a very fundamental understanding of physics, but I wouldn't say we do a ton of, it's not a ton of hardcore physics. So if someone like myself can do it, I definitely know that you guys can as well. So don't let it deter you. And it's actually kind of cool to learn some of the history of radiation and how it impacts the body and radiation biology and all of that. All right. Next question. Any advice on how pre-med can get involved in the field? So I think that for pre-meds, one of the things you can do is shadow. So I obviously, you guys are doing virtual shadowing, which I think is great. If you were interested in shadowing as a, actually going in, you could do a field like interventional radiology, which is what I'm planning on doing. Someone asked that in another question, so I'll go ahead and answer that here. I am applying for a fellowship right now, and I'm applying for interventional radiology. So I think getting in on some of that in hospital shadowing is good. Doing virtual shadowing sessions like this is very good. Global health is a great way to get started in radiology. I think if you wanted to be part of things like Rad Aid or Health for the World, there's lots of opportunities for pre-meds to help in that. I also think attending conferences is huge as well. A lot of pre-meds underestimate the importance of going out to conferences and networking. So if you have that opportunity to go to like the RSNA or American College of Radiology conference, I think that's fantastic. And then what other fields did you consider in medical school? I was all over the place. I considered everything. So I think I showed you guys that chart earlier. Hold on a second. Let me get this into presentation mode again. So this chart, I was this person. What's the problem? I liked nothing, but I also liked everything, right? So I was all over the place with what I considered. I thought about pediatrics. I thought about surgery, ophthalmology, neurosurgery, just kind of everything. And so I had really considered a lot of different things when I was a medical student, and I think that that's okay. I actually think that's the best way to be when you're a medical student, is to keep an open mind, because that way you can really fall into what you love and not just fall into the trap of like, I'm doing this because other people think it's cool, and not because it's something you like or are passionate about. Okay. And then, how are your hours as a resident? Do you have a work-life balance as a radiologist? So work hours are amazing. I definitely, diagnostic radiology is 8 to 5, Monday through Friday, weekends off, you're on call, like, maybe once a month. And then you do have night shifts, which I'm on next week, but that's just part of residency. If you don't want to do nights when you're a full-fledged attending, you don't have to. But I think the work-life balance is great. I think even as an interventional radiologist, which is what I want to do, you can modify your life to however you want. I know the interventional radiologists at my hospital, they work 8 to 5. They're on call once every 6 weeks to cover a weekend. And, I think that it's great. How did you choose the MD path over the DO path? So that's a good question. So I'm not a DO. I'm an MD. And I, at the time, and this is changing. So, there kind of was a stigma about being a DO, or having done a DO instead of an MD. And I just didn't know too much about a DO school was at the time. So I didn't apply to any DO schools because there was just not much that I knew. So I only knew to apply for MD, and that's what I did. I know that there's a lot of great people who did the DO path who ended up in radiology, and Doc Fuji on Instagram is a great resource. If you guys want to, I refer you to him. He's a program director in radiology in California. So he would be a good person to follow on social media to get more answers about that. But yeah, the answer for me is just that I really didn't know much about that path. So I just knew the path. I took the path that I knew most about, which was MD. All right. What was the biggest challenge you have faced so far as a radiologist? And are you at all concerned for the future of the field in terms of the development of automated radiology reporting systems? These are great questions. So the biggest challenge, I think, is related to what I'm doing right now. So the biggest challenge is that people don't know what I do. They don't understand the value of a radiologist to a hospital, to a clinical setting. And that's really what that's why I'm here, right? It's why I'm talking to you guys. It's why I go out there and want to educate people about all of the different things that we do, because I think it's so important that people, get FaceTime with a radiologist and understand all of the different things that we do on a daily basis that impact patient care. And that ties into, people always say, oh, there's going to be no jobs for radiologists. I think if you talk to a radiologist, they'll just laugh because there's so much more that we do than just dictating cases. We optimize protocols to lower dose. We do procedures. We talk to patients when the imaging findings don't make sense. I've gone to so many lectures about building artificial intelligence and neural networks and machine learning, and all of those things are great. But at the end of the day, it's a machine, right? And a machine can't take into context what's going on when you have imaging artifacts from your MRI or from your CT. It doesn't take into context what's going on with a patient's surgery. So yeah, if you give them a completely normal chest X-ray, maybe they could read that and chug out a report. But what happens when you have a finding, but you can't tell if it's normal or abnormal? Well, that's a problem, right? Then the machine might, and we already see it. We're using artificial intelligence in breast imaging, for example, and oftentimes it'll just say, oh, that's a concerning finding for cancer. And you look at it, the radiologist goes back and looks at it, and it's like, it's no big deal. It's a benign finding. So I think the best answer to that is that radiologists who don't use, instead of radiologists are going to be replaced by artificial intelligence, I like to say this instead. Radiologists who don't use artificial intelligence are going to be replaced by radiologists who do use artificial intelligence. And I don't think that artificial intelligence is going to replace radiologists, because there's just too many layers, too many things that we do that are involved in the quality, the protocoling, and the interpretation of images, that you can't solely rely on an algorithm or artificial intelligence to do all that work for you accurately and precisely. Okay, so next question. Any advice on how to network and get shadowing clinical hours at a hospital or private doctor's office during the pandemic? Yeah, so now I know during the pandemic, it's a very complicated sort of situation. I think what you guys are doing right now is really good, getting the virtual shadowing. I don't know. A lot of hospitals are not doing in-person shadowing. And it's not because the doctors don't want to do it. It's because of hospital policy. They're trying to minimize the number of people that are in the hospital to decrease the risk of infection and transmission. So anybody that's like a volunteer, they really just don't want them there to decrease risk of exposure. So I don't know of a good answer to that. But like I said earlier, I think a good way to network is, a lot of the conferences that you had to pay for, in the past, get a hotel, get a flight to travel to, are now all going virtual. So you can go to a lot of conferences like American Medical Association, the AAMC conference, the ACP conference. If you're interested in the ACR conference, like all of these conferences are still going to be virtual for the rest of this year, I believe. So it's a great time to get in on those conferences and just start networking with people through that, which I think is a real benefit. Okay. What advice do you have for med school reapplicants, perhaps job ideas for gap years? Okay, so this is very specific, med school reapplicants. So for reapplicants, I think the first question you have to ask yourself is why, right? Like, was there anything within your application that could have been improved, that could have changed or been different? And you have to look at that. And I think if there's an area that you can improve on that. And then job ideas, I think anything that's going to get you more face time with people in academic positions. So either as a scribe or as, a scribe is always a good one, working in an office, maybe off-site or on-site at a academic hospital like clinic or something like that. Those would all be good. I would try to steer more towards doing something affiliated with an academic hospital, because statistically you're just more likely to interact with somebody that knows someone like the dean, or that can help you network with somebody in the admissions committee. In private practice, it's good for the experience, but networking wise, you might not get the biggest bang for your buck. So go where the bang for your buck is, which is academic medical center and somewhere that you're going to have better networking opportunities. Okay.
Thank you so much, Dr. Farooq, for presenting for our web shadowers. This was such an interesting and informative presentation, and everyone appreciated all the images you included. It was an honor to have you and to learn from you. Everyone, please make sure you check out her socials to learn more from her. Her Instagram is chic and petite MD. The link to the Google form will now be posted in the chat, and it'll also be in the description of the video at the end. And also please remember that the March Roundup is this weekend. It begins tomorrow at 11:59 p.m. EST, and it ends on Sunday, 11:59 p.m. EST. To view the document with every link in every form, please refer to the Roundup tab on our website. Again, thank you so much, Dr. Farooq. This was awesome, and you gave us lots of inspiration.
Oh, good. No, thank you guys so much. It was really a pleasure, and good luck to everyone. Just keep at it. You guys are going to do great.
Thank you.